Parkinson's community and the MS community, there are specific exercise classes that are designed for their needs. You know, in MS, you want to avoid overheating. In Parkinson's, you have to respect the fact that these people have, you know, mobility and balance issues that are really going to limit what they are able to do. Someone can only exercise sitting.
Yep.
So I often will take advantage of classes like that. I think classes designed for people with arthritis, there's probably too much repetitive movement, and repetition fatigues people.
Use it or
But
lose
for
it.
the Parkinson's group, for the MS group, I think there are some classes that could be beneficial and, you know, less likely to cause harm. There are also some good exercise videotapes that have been developed by the Parkinson's Association. We did one for, you know, people with balance disorders, never got it marketed, but, you know, we worked on that one together. And I think you'll find a lot on the internet, and I know that there is some interest in the Parkinson's community, which is a very large community of older people, in getting things that can be done together in groups, getting things that can be done individually, videotapes and other things. Yoga classes are very popular and can usually be designed to respect the limitations of the person participating.
I think it has to fit the person and their needs. And sometimes the people are so anxious to get something to help them stand up or walk or be more stable that they say, yeah, I'll get it, and then it turns out that it doesn't really suit their needs. So I think it needs to be a collaborative effort with a prosthetist, orthotist, and a PT, as well as the physician.
Yeah. We really look for dynamic bracing. So obviously the material is important. It has to be lightweight, it has to be somewhat flexible, have to be able to modify it if you need to do a change, opposed to making a whole new brace. But, you know, it needs to support the muscles that need to be supported. It needs to not limit the muscles that are still functional. And it needs to give a little dynamic support to the muscles you want to give a little boost to. And, you know, it may be a jointed brace, it may not be a jointed brace, it may have different materials in it, and it really has to be individualized. And I think the braces that end up in closets are the ones that are just, you know, kind of cookie cuttered out from standard orthopedic designs, and this is not what you need for neuromuscular bracing. Some patients could never find a solid material brace that worked well, and they've resorted to using like ace bandage wraps that they themselves will kind of wrap around a joint or wrap around an area to support it, and it works just as well as an expensive brace might for that particular individual. There's an enormous amount available for pain management, and a lot greater knowledge in the medical community about how to utilize pain management techniques. You don't even have to go to a multidisciplinary pain center if you just know a few simple things. Number one, figure out what's causing the pain. Polio survivors can have 4 different types of pain or 5 different types of pain. This was written up by Dr. Gaughan. I did a beautiful article about pain in post-polio. There can be, you know, very simple neuromuscular pain, you know, neuropathic pain, you know, tingling, numbness, other uncomfortable sensations. There can be muscle-mediated pain from trigger point activity. There can be sprain and strain pain, you know, looking at, you know, joints and ligaments and tendons. And then there can be orthopedic pain within the joint itself. And each one of those types of pain is managed differently. So, you know, often physical therapy has techniques that can be helpful in managing each of those types of pain. Certain medications can be helpful for neuromuscular pain. There are a variety of medications in the anti-seizure medication family and in the muscle relaxant family, including things like baclofen, which is, you know, sort of well known, and tizanidine, which can be extremely helpful for neuromuscular pain in neurologic patients. When you're dealing with painkillers that don't work with the mechanism of the pain, but just block the pain at the level of the opiate receptors, you have to be very careful in how you use them. You have to set limits to how they're used. You have to make sure the person, you know, knows what those limits are. You have to recognize when your painkiller is not working and the dose is accelerating because it's just the wrong thing for the person to be on. You don't want to have somebody on daily painkillers because they quickly lose their effectiveness and people become tolerant to them or even addicted to them. So medication management, choosing the right medicine, choosing other non-medical strategies, you know, the psychological input, the rehabilitation input, proper adaptive equipment. I had a woman with killer back pain because of spine-related problems. The only thing that reduced her pain to almost zero was a good fitting back brace. Nothing, medicines didn't work, nothing else worked. So you really have to take it apart, look at rehabilitation, psychological, painkiller medication, antispasm medication, other medications, acupuncture, the whole range of services. You don't want to get involved in serial monotherapies where you try one thing, it doesn't work, you try something else, it doesn't work. You sometimes have to use a combination of strategies. Very careful using muscle relaxants. Traditional muscle relaxants that work on the muscle should probably not be used in post-polio or be used very carefully because there's greater risk of causing muscle weakness. Some of the ones, though, that work on the nerves and relax muscle spasm by modifying nerve input, I think can be used carefully, and specifically baclofen and tizanidine can be used in small dose and can be quite helpful. In somebody who's having generalized muscle pain, maybe relating to overuse or just weak muscles that are reacting to the pull of gravity, it's unlikely that you will find a pain medicine that will take away 100% of their pain. So you're always going to have a little bit of pain left to act as a barometer for when you're doing too much. Also, if you're doing something and there's an increase in pain that follows the activity, if that even small increase in pain persists for hours, again, it's a barometer for overuse. So you don't want people to suffer. You want people to be able to do more and not be limited by pain, but you have to educate them about the clues that they should look for to avoid overuse, because you're trying to avoid overuse. That's the main thing you're trying to do.